Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion, headache from the neurological emergency chapter. So our content wise introduction, types of headache. So here we are going to deal about the four major conditions, four major type of headaches. First one, muscle tension headache, cluster headache, migraine headache, and then fourth one is a sinus headache. And then assessment, finally how we have to approach a patient in the pre-hospital scenarios. So first is an introduction. So headache originate from the nerves within the scalp, face, blood vessel and then muscle of the neck and headache. These are the major origin area for the headache. And then coming into types. So first type is a muscle tension headache. So the name itself we can make a part. Tension means that will become a rigid or that will become a stiff because of the muscle stiffness that will create the headache. That is called the muscle tension headache, stiffness of the muscle, or you can call as a tension type of headache. Okay, the causes we told because of the stiffness it is creating. So what causing the stiffness? So what is the cause for the stiffness? There might be a stress or depression or altered cortisol level that is creating stiffness of the muscle and then that is creating the headache. So the location of the pain, it will be like a both side of the head, means bilateral, both left and right side it will affect. It will travel from the back to the front and then the nature of the pain wise dull ache or squeezing pain. So that image you can see that a sternocleidomastoid muscle is the trapezius muscle, temporalis muscle. So those are the major sites for the tension type of headache. So second type is a cluster headache. So cluster means we know that is a bunch or group. So group like, so it is a group of headache, group type of headache, cluster headache. So majorly these condition is a rare vascular headache that begins in the face as a minor pain around the one eye. So first the initial starting of the cluster headache, how it will be means, so it will start only the periorbital region. So the affected side periorbital region only it will start, and then as the time goes it will spread the whole one side of the face, unilateral side of the face it will spread. So the pain will described as a sharp excruciating pain. So the person will feel like someone is pushing the eyeball out. That much of severe will be there, and then it will spread one side of the face. As like we told, it will start first in the periorbital region and then it will spread to the whole one unilateral side of the face. So these headache occurs in a group. So again we told it is a cluster type. So group means, so the episodes that 2 or 3 or 4 episodes will occur in a day. So that is calling a group of headache. So it won't occur as a once a time in a day or twice a time in a day. So it will if once the person having a cluster headache means that will be attack in a group manner. So each attack, each episode that will be persist for the 30 to 45 minutes. So and then the person may have a several cluster headache per day. It will recur for days and then that stop entirely. That will cure entirely. So but the trigger is unclear and then there might be some chance of serotonin and then histamine alteration in the body. And then this is accompanied by the anxiety. The associated symptom is a anxiety for the cluster headache. Third one is a migraine headache. So it is a complex condition, that is two major causes that is creating the migraine headache. So what are the two major things? One is nerve origin, one is vascular origin. Nerve side we have there will be instability in the cluster of neurons. There is some instability in the cluster of neurons. Vascular origin wise, there is a diameter change in the blood vessel of the base of the brain. So those are the two major causes for the migraine headache. So the person in the migraine headache, they may report seeing some aura. So aura means we know that is some set of clinical manifestation or some set of clinical symptoms that will occur before the disease. So in migraine, the person may feel some blackout or the person may feel some flashing lights. So those are the some aura that will occur in the migraine type of headache, and then the location of the pain is a unilateral, so one side only it will affect. The nature of the pain is throbbing, bounding, pulsating pain, and then that may associated with a nausea and then vomiting. So he or she may prefer to remain in a dark area. Photophobia will be their quiet environment they will prefer. And then migraine headache that can last for several days. Fourth one is a sinus headache. So sinus means we know that is a air filled cavity that is present in our skull. So we have a four major signs: frontal sinus, ethmoid sinus, maxillary sinus, and then sphenoid sinus. So whenever these sinus getting infection or inflamed means that will create the headache, that is called the sinus headache. Mostly it will occur in the superior portion of the face, and then most provoking factor for the sinus headache is a leaning forward, or in the early morning that will the intensity of the pain will increase, or waking up from the bed. So those are the some provoking factors for the sinus headache. And then these things accompanied with a post nasal trip, sore throat, and then nasal discharge. Those are the some associated symptom also will be there. So again, coming into assessment part, so mostly headache we will think as a it is a common, otherwise it is a minor symptom, but we don't know that might be a simple migraine, otherwise that might be a stroke, that might be a subarachnoid hemorrhage, but the exact cause we don't know, but it will showing only the headache. So headache it is a minor symptom, but we are thinking as a minor symptom, but that might be a sign for the major life threat. So while handling an headache case, we should not have a tunnel vision that might be a migraine, that might be some red flag syndrome also, like a red flag syndrome, some life threat also. So while the time of assessment, we have to clarify first. In a pre-hospital situation, we have to clarify, or we have to rule out the major life threat first. For like if you can think about the stroke, so you have to rule out the stroke related things. So we told fast we can do, so the fast assessment. So facial drop, and then arm drifting, and then slurred speech, those are the some symptoms that will signs that will occur in a stroke, so that we can assess. And then we can think about the seizure related things. So aura stage of seizure also, those are the headache can occur, that we can rule out seizure related things. And then we have to report about the, so some set of cases subarachnoid hemorrhage, the person that maybe have a thunderstorm headache, so the person they will tell a worst headache of their life. So that is also one of the thing, a major clue for the subarachnoid hemorrhage. So that is comes under the hemorrhagic stroke, right? So that we have to rule out. And then sleep wake pattern, and then behavioral history. Some person they may have a lack of sleep in the past days of the attack, or past days of the headache. So that we have to rule out. Lack of sleep means then we have to give providing some sleep pills, that is mainly managing in the in hospital. But while the time of ruling out the history and then assessment part, we have to rule out the sleep pattern. And then we have to ask about the GCS, we have to rule out, we have to assess. And then pain score for the headache, so we have a 1 to 10, we can include 0 also, but 0 indicates the no pain. So the pain score, based on the pain score 1 to 10, we can ask the severity of the pain. And then past medical history, previously they have any trauma related history, or any history of fall, or any history of previous attack, headache related thing we can ask about. And then associated symptoms, so cluster headache we told, anxiety in the type of migraine headache, so we told some nausea, vomiting, right? So associated symptom, anything is there or not, that we can rule out. Glucose level, so hypoglycemia may precipitate to the headache, that also can occur. So and then so we have to check about the glucose level. And then we have to ask about the medication. So if you took if they took any painkiller or analgesic, means what the drug they took, what's the dose, when they took, any palliation or any relieving from the pain is there or not, that palliative factor also we have to rule out for the, in the case of assessment in the headache. So management wise, scene size of primary survey, general impression, AVPU, mental status, ABCD, everything we have to rule out. So we should be care about more conscious about the mental status. In the case of stroke or in the case of subarachnoid hemorrhage cases, there may be a depression in the consciousness, mental status. So we have to manage accordingly. Airway, everything should be taken over. And then mainly in the case of headache, we have to manage about the pain management is one of the major important thing. So here we wrote about the based on WHO, World Health Organization, we have some thing like a step ladder pattern pain management. So from mild to the severe, we have a, so based on the mild, what are the drugs we have to give. Moderate pain means some a recommendation from the World Health Organization. So I'll tell one by one. So mild pain means in pain score that will be like a 1 to 3. So that is categorizing as a mild pain. 4 to 6 means that is a moderate pain. 7 to 10 means that is a severe pain. So usually we have a pain score that is start from the, actually it is start from the 0 to 10. 0 means that is no pain, so leave it 1. So 1 to 10, that is a, you have to ask the person, so rate the or tell some scoring about the pain. So you have to ask the person, they may tell us a 7 means, so that is indicating as a severe pain. If they are telling us a 3 means, that is indicating as a mild pain. So if the person is telling like a, if a person is falling under mild pain means, the treatment is a NSAID, non-steroid anti-inflammatory drug. For example, we can give the paracetamol and then ketorolac. So those are the coming under the NSAID. So once after giving an NSAID, once after administration of NSAID, after 60 minutes we have to reassess the patient. So again we have to ask about the pain intensity or pain score regarding things. So after 60 minutes. So what is the major important thing we have to remember in NSAID means, before giving an NSAID, so NSAIDs are, we have to rule out about the renal function test, renal function related thing we have to rule out. And then other most important thing, we have to give the test dose of the NSAID. So if you are going to give a paracetamol means, first we have to give the test dose. That is also most important, because these are the oriented with an allergic related things, right? So but for that reason we have to give the test dose. Second important thing, we have to give the we have to rule out the history regarding that renal function. So this is the thing we have to remember in the NSAID. And then coming into moderate pain, if it is the person is falling under 4 to 6 means, there we can give weak opioids plus or minus NSAIDs, or means weak opioid with or without NSAID. That is a treatment for the moderate pain. So weak opioid means we have a tramadol. So with or without NSAID we can give the NSAID, we can give the weak opiates. So once after 30 minutes, we have to rule out, we have to reassess the case. So if it is a severe pain, more than R7 or 7 to 10 means, there we can go with a strong opiates. So strong opiate means, for example, morphine or fentanyl, those are the strong opiates that we can go with or without NSAIDs. So after 15 minutes of administration, drug administration, analgesic administration, we have to reassess the cases. So what is the major important thing we have to keep in mind while administrating opioid means, there might be a chance in respiratory depression. So if you are suspecting the case as a subarachnoid hemorrhage, so already there will be a pressure over that respiratory center. Because of the increased cranial pressure, there will be a alteration in the respiratory pattern. So that we have to keep in mind. So again, if you are giving opioid analgesic, so that will create a respiratory alteration, means that will make a complicate in the case. So before giving an opioid analgesic, we have to rule out the increased ICP level and then respiratory pattern, rule out about the hypotension. So again it will cause a hypotension in the case of toxicity or in the case of overdose, right? So those are the things you have to keep in mind. And then we have to treat the associated symptoms. So ondansetron, so we told nausea, vomiting is an associated symptom in the migraine headache, so we have to treat about the that condition also with the emisset. So in hospital management, mainly analgesic, and then we have to rule out the specific life threats or which causing. So sinusitis means, based on the PNS X-ray, they will go for the imaging and then they will manage the condition based. So do your best. Shalom.